thanks for accepting this invitation of the fourth Symposium International for Fertility and Reproduction. My name is Andres Leonardo Naranjo. I am a specialist in human reproduction in South Colombia, and my topic is ovarian stimulation and induction in PCOS, Polycystic ovarian syndrome. On the ovarian stimulation and induction, it's a treatment, basic treatment, a common treatment for women with polycystic ovarian syndrome, especially for those seeking to conceive. And everybody knows that the PCOS is a hormonal condition that can affect the correct ovulation, and proper management is crucial for alleviating symptoms and enhancing fertility. The different presentation of this pathology, the consensus of the Rotterdam speak to three conditions to speak how PCOS. One, morphology of the ovary in the ultrasound, polycystic, and the volume major than 10 centimeters 3 and more than 25 follicles in the count and follicular count antral. The second condition of PCOS is oligoanovulation, and the third is hyperandrogenesis clinic of biochemic. The oligoanovulation is the principal treatment. The strategies for ovarian stimulation, the first is lifestyle modification. Before initiating medical treatments, it is recommended that the woman with PCOS adopt healthy lifestyle habits, such as balanced diet and regular exercise, which can help regulate menstrual cycles and improve ovulation. In the first interview, we need to orient the patients to take a balanced diet and less food processed, more healthy diet, and start up regular exercise every day. This is the first step for the ovarian stimulation. You should be required at nutrition and exercise. And the strategies for ovarian stimulation. The medication, the second step is the medication for inducing ovulation. And exists 3 different medications. The first, clomiphene, commercial clomid, Simakin. This oral medication helps induce ovulation by blocking estrogen receptors in the hypothalamus, that increasing the production of hormones that stimulate the ovaries. The second is letrozole, commercial Femara, originally used for the treatment of breast cancer. This medication has also been shown to be effective in inducing the ovulation in women with PCOS. And the third is the gonadotropins. In some cases, injections of gonadotropins might be recommended to directly stimulate the ovaries. The strategies for ovarian stimulation are referred low complexity, in this case clomiphene and letrozole, because of our medication that the oral take, and the high complexity is the use of gonadotropins. In the next slide, we talk about the clomiphene and letrozole. We have a strategy to the low complexity if you can do in your consult. In these strategies, that ovarian stimulation and additional therapies, the use of metformin and oral medication commonly used to treat type 2 diabetes might also be beneficial, as it can improve insulin sensitivity and help with ovulation. The 3 steps for ovarian stimulation. The first step, change some topics of the diet, and take regular exercise. This load the insulin resistance, and the other strategy is add to the management the use of metformin. The metformin, the dose is initially 500 milligrams with the lunch, and you should be increased to 850 with the lunch, 1 take or 2 today. The problem of the metformin is the secondary effects and abdominal discomfort and others. But plus the balanced diet, regular exercise, and this is the test for ovarian stimulation. You should be take good ovulation in these patients. And these considerations, monitoring ovulation is crucial, which might include ultrasounds and blood tests to check hormone levels. It is important to work closely with a fertility specialist to tailor treatment according to individual needs. And the good practice is take exam to permeability of the fallopian tubes, and take before start this strategies to stimulate the ovulation. Before take a exam to fallopian tubes and as sperm ones, masculine factor masculine in the spermogram, and this exam should be stick good, okay. And the other considerations is the transvaginal ultrasound to follow the different strategies to induction the ovulation. Because this treatment have risk, and the principal risk is ovarian hyperstimulation, which can lead to complications. Therefore, medical follow-up is essential during the treatment. This is hyperstimulation of ovary secondary to use of gonadotropins. This is in treatment of complex, but the risks without the follow with ultrasound transvaginal is have a high organ pregnancy, 2, 3, or more. If you not do the different vaginal ultrasounds, you should be take 2, 3, or more follicles and take a high organ pregnancy. Here's the low complexity induction ovulation scheme. The first is clomiphene C-traps. The clomiphene C-traps block the receptor estrogens in the hypothalamus, and the hypoestrogen needs take the pulse of the GnRH in the pituitary gland, increase the concentration of the hormone follicular stimulation, and the ovary is stimulated to grow the follicles. This is the form of the clomiphene C-trap acts. And this the treatment protocol in C-traps or clomiphene. The dose initial is 50 milligrams per day for 5 days. Starting then between days 2, 3, 4 until 5 of the menstrual cycle. Can be increased to 100 milligrams a day in subsequent cycles if ovulation does not occur. The memo technique for this is that I start 1, 2, or 3 tablets of clomiphene C-trap, and generally we use two tablets starting between day 2 or 5 of the menstrual cycle. This is with graphic image that the citrate of clomiphene 50 to 150 milligrams a day, and I take unit of the day for 5 days. In generally, the start 3 days to 7 days of the menstrual cycle, and after 2, 3, 4 days after the last period, we start with the ultrasound, pelvic ultrasound examination ultrasound, and we length the follicle. In this treatment protocol, the other medication is the letrozole, and the letrozole, the tablets are the 2.5 milligrams, and we can start 2.5, 5, or 7.5 milligrams per day for 5 days. The scheme of induction of the ovulation is similar to the citrate of clomiphene, starting between days 2 and 5 of the menstrual cycle. This is other scheme induction of ovulation with letrozole. In the menstruation, we do the first ultrasound, transvaginal ultrasound, and if you not have cysts in the ovaries, you should be start the letrozole 2, 3, 4, or 5 days. You can to start the day 2 at day 5 of this menstrual length with 1 tablet, 2 tablets, or 3 tablets. 2.5 milligrams per day, or 5 milligrams per day, or 7.5 milligrams per day for 5 days. And you should be do the ultrasound transvaginal 2 or 3 days after the last pill of letrozole. In this treatment protocol, the monitorization is crucial. Transvaginal ultrasound are around day 10, 12 to evaluate the follicular development. And you should be, this is optional, measure hormones to check the increase of LH and follicular maturation. This is an example for the ultrasound cause of the induction of ovulation. The A and the scheme B are the first ultrasound. I see the patient with the menstrual length, the first, the second, or third day of the cycle. And this is the image. This is the uterus and the endometrium, lineal endometrium, and the follicles and trials, all these less than 10 millimeters. If I take this image A, B, C, I can to start any of 2 medications, clomiphene citrate or letrozole, the day 3. Generally, I start 2 pills or letrozole or citrate clomiphene for 5 days. The day 3, 4, 5, 6, 7 for 5 days. And 2 or 3 days after the last take of pills, the citrate clomiphene of Femara, I do a ultrasound. In this ultrasound, the second ultrasound, DAF, I have a 3-laminar endometrium. If the endometrium takes the confirmation of 3-laminar, I know that the estrogen is active. And then the ovary and the ultrasound of the ovary, I see a follicle in growth around the 12, 15 millimeters. And after this ultrasound, I do an ultrasound 48 hours, 2 days or 3 days after of the second ultrasound, and I should be administer the inductor of the ovulation with Ovary or with HCG. And the last ultrasound my follow is a week after the trigger. A week after the trigger, we can see free fluid and the forms of sac and the disposition for ultrasound of the corpus luteum. This is a schematic form to the different ultrasounds, transvaginal ultrasound for follow the induction of the ovulation across the cycle. And in this treatment protocol, the detection of the ovulation, we can't use text to detect LH source, scheduled intercourse, or artificial at the appropriate time. In this graphic, we follow the growth of the follicle to diameter to 18, 19, maybe 20, maybe 21 say millimeters of diameter, and 18, 19, 20 we can prescribe the trigger. The trigger is the Ovarian and HCG, and or we can test to detect the LH source. And when I prescribe the trigger, or when I detect the LH source, we recommend the cellular intercourse, the low induction or low complexity, or when I prescribe the LH, the ovary, we can to prepare to artificial insemination. In this treatment protocol, post-treatment follow-up I can confirm ovulation by analyzing levels of progesterone in the luteal phase, and maybe more than 2 of progesterone is indicate to that the confirmed the ovulation. And 2 weeks after, or if menstruation is absent, we can perform pregnancy test, and if the pregnancy test is positive, we can start the follow-up of the pregnancy. But if the pregnancy test is negative, or the menstruation is present, we can repeat these steps 3, 4, includes 6 months in the patient's anovulatorias. And this is a scheme on resume these topics. Life in the induction of the ovulation, lifestyle improvement with reduction in these patients, improve the ovulation, and if pregnant, the pregnant is absent, clomiphen or letrozole. If that obtain the pregnant, we change to our control of the pregnant. But if it's negative, BMI more than 28 plus metformin are tools. Citrato de clomiphen is better. If less than 28, letrozole. If no pregnant, the last step is gonadotropins, in vitro fertilization. The use of gonadotropin for in vitro fertilization is an induction of ovulation, the high complexity, and you should be referred to a specialized in reproduction. Now, this is other graphic that resume these topics, that a typical oral ovulation cycle timeline, and the first days of with the menstrual leg of the patient, we take up ultrasound, maybe can to take blood work if hormone follicle stimulate, LH, estrogens, HCG, progesterone, 2, 3, 4, 5 days. Now, the ultrasound in this phase of the menstrual length is see the ovaries and not take cysts. If you don't see cysts in the ovaries, you can to start the clomid or letrozole the 3, 4 or 5 days for 5 days, and the day 10 or 12 of the cycle, you perform the second ultrasound, and you should be take a follicle in growth, one or two, more than two most correctly. See, if you see in the ultrasound 3 or more follicles, more than 14 millimeters, the vessels can sell this cycle, and the next stimulation you should be use less clomid or less letrozole. We typically start 2 clomiphene, 2 tablets of clomiphene, 2 tablets of letrozole. If you in the second ultrasound you see hyperstimulation or more than 3 follicles, you can sell this cycle, and in the next month you should be start with one tablet. And before of the second ultrasound, 2 days after, you should take a new ultrasound. And when the growth follicle 1 or 2, the 18, 19, 20 millimeters, you can prescribe the trigger Ovary or HCG and program the intercourse, the relations between the patients. And one week post the relations with this, you can take in levels of progesterone, and the level of progesterone is more than 10, the ovulation is good, or more than 2. And 2 weeks after, you can take the pregnancy test. If pregnancy test is positive, change to or control the pregnancy. If the pregnancy test is negative, or the patient presents you menstrual length, you can restart this scheme of induction of ovulation. And this small slides, this slide is based on the international evidence that's guideline for the assessment of and management of polycystic ovarian syndrome in the 2023, and the different societies, and specifically the Chapter 5, Assessment and Treatment of Infertility. And thank you.